All right, well, we might kick off because I appreciate that people's time is very precious at the moment. So firstly, I'd like to welcome everyone and thank you all for joining us today. Before we commence, I'd like to acknowledge the traditional owners of the lands that we're all meeting on today. For me, it's the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present and emerging, and to any Aboriginal people joining us here today. So today is really to connect our members together. We have been hearing your concerns over the past few weeks, or the past years now, as we move into 2022. So I think for me, what I've heard, and with Susie and other staff members at NADA, what we've heard is the most immediate issue is access to rapid antigen tests, or RATs, to enable services to manage risk to both their staff and to clients. We've heard a lot about the workforce issues. We've heard about the availability of the workforce due to illness and stress, needing to isolate, recruitment issues, lack of access to a casual pool. And I think the other main thing that we've heard is about confusion, or the need for clarity around what guidelines and processes and protocols to follow. In particular, residential services are in a position where they're not sure whether they should look at guidelines relating to aged care or public health facilities. So I know that you're really keen to hear from people from the ministry to get some clarity on that. So I know that the ministry have been doing some work. There's a Resi Rehab survey out there for residential services, so I would encourage you to do that survey. And from the NGO community of practice point of view, there's a special meeting on Friday specifically to talk about getting access to RATs for health-funded non-government services. I'd like to welcome Dr Tony Gill to the meeting. Tony's the Chief Addiction Medicine Specialist at the New South Wales Ministry of Health. And Tony has agreed to come and talk to us today to answer some questions. Tony, was there a particular update that you wanted to provide from the ministry? I know I've provided a very long list of questions for yourself, and as well, we're going to be joined at 2 o'clock by Dr Jan Fizzell, the Senior Medical Advisor as well, to answer some more public health related questions. But Tony, might hand over to you if that's okay.
Yeah, look, sure, Robert, and thanks for inviting me. I mean, I'm interested to hear from people today at this webinar. I mean, I know we're all looking for very clear and explicit and direct guidance on a lot of things, but we are in an environment where things are evolving quickly and changing rapidly. And so, you know, we do need to be flexible and to kind of deal with things as best we can as we go along. But I appreciate that this is a particularly tough time, and I guess wanted to begin by just acknowledging the work that you're all doing in this really tough last couple of years. It's been an incredibly challenging time with lots of changes, lots of new problems that have been emerging, and this latest wave is complicated things even further. So I just want to acknowledge the extraordinary work that you're all doing in really difficult circumstances. In terms of the situation at present, you know, I think you're familiar with, there's been a lot more information actually out in recent times than perhaps there was in the past about what's going on. And we know that this current wave, which is now very much predominantly Omicron, I think about 95% of the community infections now are Omicron, is a different wave in that it's obviously high transmissibility, but probably less severe disease. But even so, we're expecting the peak of this wave to be sometime the end of this week, early next week, into next week. We're hopeful that things will kind of taper off a bit. The latest data suggests that it's possibly not going to be as big in terms of its impact as we thought it was going to be, but it would still be incredibly substantial. But then when the waves flattened out a bit, it just means that the peak can occur a little bit later. And so that's probably what we're looking at, but sometime towards next week. I think that there are, you know, obviously many things that we could talk about in terms of, you know, what's going on at present. The big issue, of course, is around the access to rapid antigen testing. There is really beginning towards the end of last week and now this week, increased availability that's occurring in New South Wales and through the Commonwealth as well. This is going to be occurring over the next 2 to 6 weeks. The availability of rapid antigen testing will increase. There's still going to be tough times this week and certainly next week, at least, in terms of accessing rapid antigen testing. But it will start to get better, and then they will start to be more available in the ensuing weeks. And I can tell you that they're not just problematic for the non-government sector, they're also problematic for the government sector as well. And getting hands on rapid antigen testing really everywhere is a hell of a challenge at the moment.
Tony, can I just ask a question on that? Because that is one of the main things that I get asked about.
Yeah.
And I guess being privy to the Clinical Council, I do hear that it's not just unique to NGOs, that public health services are experiencing the same issue. So how are you managing risk in not being able to access in your own clinical practice or in the area that you're working in to manage risk? Yeah,
that's a good question, Robert. I mean, I'm currently, I work in the ministry, but also work in Southern, which is a local health district, which is probably not the most flush with within really, but we had no rapid antigen tests available to us until last Thursday. So we were operating simply on a process of, all the standard measures, which was to do with screening patients, which was to do with distancing, which was to do with doing as much by telehealth as we could, being really vigilant around, things like how we assess people and ask about their vaccination history and their exposures, but also really vigilant around things like hand washing and, wearing masks and distancing and washing down surfaces and all of that sort of stuff. So that's how we've been managing. And most people, I think, have been managing and just being, cautious. We've now got access to a small amount of rapid antigen testing. We don't have enough access to utilise it with our client population. So in our drug and alcohol services, we have staff testing before work 2 days a week, Mondays and Thursdays, spread out across the week as our way of keeping an eye on staff and obviously being incredibly vigilant around any symptoms at all when people just don't come to work. And we've split up into Alpha and Bravo and sometimes other teams to make sure that staff aren't coming across each other during the week, so that if one group goes down, then we've got another group to continue the service. And I think that's been a very important introduction over the past 2 weeks or 3 weeks, really, certainly before rapid antigen testing has been particularly available for us. And so that splitting up and that new way of operating where we had teams separated physically is also an important aspect. Yeah, great.
Well, look, Tony, I might put it out to the members now. We do have a long list of questions that we'll provide to Jan when she comes on board. But the other purpose of today was for you all to talk to each other and share your own practices and how you're managing the situation at hand. We know from talking to members that there's probably about 7 Resi services that have been managing cases or still are or have been. And I know that there's been varying degrees of mostly good support from the public health units within LHDs. And of course that varies. So it would be great to hear what questions you might have for each other or experiences that you'd like to share with each other. I think it's great for Tony to be here as the chair of the Drug and Alcohol Community of Practice as well. It's really useful for Tony to hear what some of those key issues are as the Chief Addiction Medicine Specialist, so he can also advocate on our behalf when he's in ministry meetings. So if you can use the put your hand up function or just ask a question. Perhaps I'll ask a question that's been put out to me from a member that was interested to hear from other members in how they're managing situations. So one of our staff members asked how other services are doing leave for positive cases or close contacts for staff. We know that workforce is a really big issue. So how are other services managing maybe having a lack of staff or having staff off because they've been identified as a close contact. We're really interested to hear what you all are doing. David.
I'll start. No,
Thanks, David.
I think I may have asked the question as well.
You did.
I'll answer my own question. So, and I just genuinely, because I think we've all had our head down dealing with the dramas, even, services that are, quite close to each other or have other opportunities to meet with each other regularly have been a bit flat out lately. So we haven't had the chance to ask each other these questions, which is why I thought some of these might be useful just to talk to each other about. And I think the question from me was for both things. One, managing with so many staff on leave, just how are people managing that? But also the kind of the industrial thing. What I was genuinely curious what other services were doing with regards, leave, people who are on who need to be on leave because they're a close contact, and that'll be another question for public health, how we deal with close contacts, but we'll talk about that later. But what leave, and are people using their own personal leave? Are any other services offering COVID leave in addition to their personal leave, and that sort of thing? So for us at the moment, staff are using their own personal leave in both the situation of being a COVID positive case and in the situation of being a close contact, unless in the situation of being a close contact, they're able to work from home. And if there's any way we can help them to work remotely, then they will. But we're looking, having concern that some staff, I've got a staff member who's off this week, who's on her second round of being COVID positive just in the last sort of month and a little bit, very unluckily for her. She will be out of sick leave just with being caught twice. So we don't have an answer yet, but we're looking at what we might do in that situation. Last year, when we had an outbreak, we did pay people who were off outside of their personal leave because they'd all become close contacts in the workplace. So we did pay them, but that hasn't been an ongoing thing. So I've been interested what other services are doing, particularly services that have cases in their service, for example, so staff are coming into contact with that in the workplace. So that's a long question and answer.
Thanks, David. No, I think that's really useful, and I'm sure it's an experience that other services are grappling with. And I know that one of the questions that I had come to me was around whether workers have access to the pandemic leave disaster payment, that $750 payment. Is that something that you've explored at Odyssey, whether that person who's used up their sick leave is able to access that payment?
Yes. And so last year, there was a similar example, and someone who just used up their leave prior to COVID, just coincidentally, and that person was able to access because they didn't have access to any other, like you have to have exhausted your options with your employer. But after that, you do have that opportunity, yes. And employers can choose to allow people to take, obviously, unpaid leave, but and everybody, by the award from my understanding, has the opportunity to take unpaid COVID leave without the normal restrictions. But employers also have the opportunity to offer people to use their annual leave and those sorts of things. But staff are able to take get the pandemic allowance if they're not able to access any other sorts of payment.
Great, thanks. Jackie, I can see you've got your hand up there. Did you want to speak?
Yeah, thanks, Rob. I'll talk about what we're doing at Jarrah House. We have had a staff member return positive, and we've had several people be either close contacts or high or moderate risk exposures under the new definitions. Our staff are under modern awards, they're federal awards, and the unpaid pandemic leave provision that was there, meaning they don't get paid for being off, but they get their entitlements accrued as if they were working. They ceased on the 31st of December, haven't been extended. So our staff are taking leave without pay if they're a contact but not symptomatic, or they haven't contracted COVID. If they're symptomatic or have contracted COVID, they're getting access to their personal leave. If they run out of personal leave, they can make a choice to either be on leave without pay, or we'll give them access to their annual leave. So if they've saved up any other leave provision, we'll give them access to that to support them financially. And only after they've exhausted that, as David has said, they can get access to the federal supports.
Yeah.
One of the things that's good about offering leave without pay in the first instance is it stimulates the conversation about how they wish to use their leave. They've all been advised that they can get access to it. They just have to have a chat with their manager. But it also means that if they come off the roster in one fortnight or week, they might have access to some additional shifts in another week if somebody else is off. And occasionally that also means they get access to a bit of overtime. So it so far seems to be working out that people are not wanting to access their other leave, their actual holiday leave, if they've been on leave without pay. So far, so good.
Thanks, Jackie. And Anna, you've got your hand up. Anna, we can't hear you. I'm not sure if you're on mute. Hello? No. And we might need to get you to write in the chat function to get your question through. Joe Coit?
Yeah, mate. G'day, Rob. How are you?
Good, thanks, Joe. How are you?
Not too bad. Yeah, no, we've had a few staff members catch COVID, including myself. I'm actually COVID positive at the moment. We've had a lot of us, actually, we've also had a lot of close contacts and that. I think we've been lucky enough that we've been able to utilise working from home. So I think some of the things, so it's probably not real helpful, but in regards to answering the question, we learned a lot about working from home last year when we were all forced to, and essentially there's no one really in our organisation that if they're isolating, there's not something they can do. So we've sort of been able to navigate it that way. Yeah, they're probably not delivering the amount of service they would obviously if they were inside the service, but really focusing on not just delivering the residential program, but really we've been focusing hard on catching up with people who are ex-clients, because I suppose one of the things we looked at was, okay, we're going through this situation at the moment. It's hard, it's different, but that's also the real world situation for a lot of our ex-clients who are out there. So worst case scenario, someone might just spend the day going through and ringing the people who are in our outreach program that might have been contacted for a while, touching base, and if they need any help or referrals, just sort of helping them out that way. So not real helpful to the question, but we've been able to just sort of get away with it that way.
Great. Thanks, Joe. There's a question from Marianne and/or Miranda from MSIC that's keen to hear about whether boosters will become mandatory as part of the public health order. And that's on my question list for Jan Fizzell. So hopefully she'll be able to answer. If not, I'll take that to the NGO Community of Practice on Friday to seek some clarity on that one. We've got another comment here from James, who's talked about since the start of the pandemic, they've moved from face-to-face counselling and talking about the increase of client. It's resulted in an increase of clients and overall positive experience, except for the isolation from working from home and the longer hours that has resulted from that, which I think we can all relate to. Brendan, I saw Brendan had his hand up, but it's moved down. Not sure, Brendan, if you had a question or if it possibly was answered.
No, I was just going to say that, like a lot of people are saying, with paying COVID leave depends on, we're under the private hospital here, and they'll pay you COVID leave if you caught it through your work. So if you got it at work, they'll pay you. But if you have been out and about outside of work, you have to take your own leave. Yeah.
Okay, thanks, Brendan. And Christine from Guthrie. Guthrie has paid pandemic leave for all staff inclusive of penalty rates, and this may be used for isolation period, COVID positive or contact. And Anna has sorted out the mute now. Anna, welcome.
Hi, thank you. Sorry. Yes, no, same here at Carolina. We've got our own enterprise agreement. And within that agreement, there is a clause of CEO special leave. So we initiated that in 2020 for anybody who needed to isolate whilst they're getting tested. If they become sick in that time, they take their own personal leave. But whilst they're in that isolation period, whether they're positive or waiting for results, we initiate that payment. Most staff can work from home. Some of our resi staff, it's not job role appropriate working from home. But most staff, yeah, we've now got our tech up to date, and most people can do some work from home. And the only other one is if people are at home looking after children, then that's on their personal leave as well. But same thing, if we haven't had it yet that people have run out of their personal leave, but they can access their annual leave and then long service leave. Our casuals have accessed their long service leave and also the payments because they're not included in that. It's only permanent staff that are included in that. Yeah.
Thanks, Anna. And someone has commented if we could get people to introduce themselves and their service when they speak. Thanks, Susie, for identifying. That was Brendan McCorry from Calvary Riverina before, and Anna from Carolina just now. Leonie from the Buttery has asked, have people thought about using work cover, and has any other services had a resident COVID cluster outbreak? Lartha, you've got your hand up.
Oh, yes. My concern is, so far we've been very careful not to have a COVID case in the service. So all staff are prepared, to be working from home. So even if they have to be isolating, their system is set up that they can work from home. My biggest concern is if a client gets COVID, we can manage. If one client gets COVID, we can, isolate one client. But if we have more than one client, because it's a small service, we would be very difficult to isolate them with the rest of the clients. Has anyone, any small services had some such issues, and how did they handle that?
Thanks, Lartha. It's a good question. And I know we have had some experiences of LHD supporting people in hotels, but I know it's not consistent across each LHD.
I've had some assurances last time before the Omicron happened that they would be supporting and they'd be able to put up. But now with this Omicron, with everybody being inundated with things, I'm not too sure what kind of support I'd be able to get.
So I've definitely added that question in there, Lartha, and we can follow up specifically with your LHD. Jackie, I'm not sure if your hand is up again or if it was up from before. No, I'll take that as from before. Levi.
Hi guys, Levi from the Haymarket Foundation. I work from the Burke Street program with our foundation, and just to answer a question around like residents contracting COVID, we have had a couple of cases, and how we were able to manage that was from the beginning basically drafting up a template of like contract tracing to see what clients do we have, where do they reside, are they fully vaccinated? Doesn't matter if they are or they're not, but we have that information just to know. And are they able to self-isolate with any supports? So any supports meaning, would they need any food hampers delivered to a property? Because we work at a residential out of community housing, we're able to hopefully only isolate one property. So if we have our program and one guy contracts COVID, that house will all go get tested. We don't go onto property without wearing full PPE, so taking care of ourselves. And yes, with the whole rapid antigen test, they're so difficult to come across nowadays. But when we do have them available, we will test them as well. So basically, if the guys do contract COVID, we just call them up and just basically do our own contract tracing. Go, when did you start feeling sick? Who in our program did you hang out with? Where did you go? Sort of just asking those relevant questions and double checking with them and seeing what they've been up to. And if they do need any supports, like if they live in a house with 3 or 4 other guys, can they help and support by cooking meals and dropping out the door, keeping their distance and all that sort of stuff, just to keep positive communication with one another. Because our first case, they were isolating for 14 days, and 14 days of sitting in your room was, I had to myself sit in a room for 14 days and it was madness. So those are the small steps that we started with, and it's sort of how we've just been going on with it, I guess.
Right, thanks, Levi. Leonie, did you have a follow-up question?
I suppose just, can you hear me?
Yep.
I've got some technical issues. So I'm Leonie from the Buttery, and we're in the northern and Mid-North Coast. We had a cluster outbreak, so 50% of our residents were COVID positive, and we did approach public health, and they were very supportive on day one, and never heard from them again, nor did they answer any of my calls or contacts. I did what Tony did and created alpha beta teams. I had thought I had enough RAT tests, but didn't expect 50% of people to contract the illness. So I just managed it with the 7 days isolation, moved them all into the one property. Luckily, I had some oximeters, which I could test their pulse and at least their oxygen saturation rates to see if I had a deteriorating person. It was completely nerve-wracking, and we actually realised that we're on our own. So we've done it. The last person comes out of isolation today. So we've been using the 7-day procedure and then doing 48 hours after COVID symptoms. The problem that I have had, and I'm not sure if anyone else has experienced that, is people, when they find out that they're COVID positive, and I rationed the RAT test because I did it by symptoms, and luckily, I've got a couple of us have got a clinical background and we're quite observant. We could tell when people were sick, and often they don't want to tell you they're sick because they want to leave. And under the actual requirements, you're supposed to actually ring Crime Stoppers, which we haven't done. We've decided not to do that because I feel that that's quite punitive, and I don't think anyone in Crime Stoppers would actually care, because how many cases are out there. But, I just wondered if that could be taken to the council possibly, Rob, because that's, quite a punitive way to do that. People they are voluntary. So if they choose to leave, I do understand if they're positive, that's difficult. I don't think I had anyone in the end that did leave positive, possibly a very close contact, and because they were also what Levi just said, I think it was Levi, I apologise if it wasn't, what you just said, 14 days isolation, we're doing 7 and then 48 hours just with asymptomatics. So I just don't know if anyone else had that experience, because it was pretty, like today's the last day that the last person's come out. So, I haven't, well, everyone's been working pretty much non-stop for, 16 days. I don't think I've had a break. But we're lucky that we did get some, but our PPE's down. I know RAT tests are difficult for everyone, but we really, really struggled. I was nervous because we didn't have the P95s, Tony. They are the best protection, I believe, in terms of safety around masking. There's plenty of masks, the normal surgicals, but I didn't have enough P95s, didn't have enough gowns. I was doing all the RAT testing myself, and then I've taught the residents how to do it, and also got some help. Learn how to do the PCRs as well, because you can do a PCR with anything, which maybe that needs to be kind of talked about as well, because you can do PCRs with swabs. You might not be able to get RATs, but you can still send it off to a laboratory. So there's all those things that I've learnt. I don't know if they're useful, but I'm writing a comprehensive plan as I go. So there you go.
Well done, Leonie. And there's lots of comments in the chat function praising you and your team for managing the situation. And it's a shame that the Public Health Unit wasn't able to provide more support in the North Coast region.
I think they were inundated themselves. Like we had a per capita, Byron had a per capita. It was always predicted, but Byron got the per capita cases exactly the same as Sydney. So they're inundated themselves.
Thanks. I'd like to welcome Dr. Jan Fizzell to the meeting.
Hi, everyone.
Thank you so much for taking the time, Jan. I'm sure you're in demand and probably sitting on a lot of these Zoom meetings throughout the day. How are you first?
Pretty tired, but we're hanging in there. And just to say thank you for the acknowledgement. The public health units have been absolutely inundated. I know it's been hard for anyone to even get through to a public health unit. And then when you get through to a public health unit, you may not find a person who can actually help you with a quite complex problem. And so it has been really difficult. It's also been really difficult for us on this side when we only find out about complex problems when they're actually solved, which is kind of nice in one way, but really heartbreaking in another. So just to say thank you to everyone who's soldiering on at the moment. It's a very changed environment and a really difficult environment. And I know for all of you, you were hit pretty hard with Delta, and Omicron's here to basically, you know, try and throw us on the mat.
Absolutely. And so I think, I mean, as part of the intro, Jan, we talked about the fact that the majority of services here online today are non-government drug and alcohol services, predominantly residential rehabilitation services. And I guess they fit in a place where we're a bit unsure around guidelines. We're not considered part of the public health system, but, you know, are we priority settings? And that's part of, or high risk setting, I should say. And I guess that's part of some of the questions that we had for you today to try and support some members in making sure that they're providing safe care for both their staff as well as for their clients.
Fantastic. And just to acknowledge how challenging it is at the moment. So thank you, everyone, and here to try and help. So I think you've sent me through a list of questions that you'd like me to address. How would you like to go about this one? What's the natural flow for this for you?
Well, I guess one of the main issues is around access to testing. I think is probably one of the biggest issues that our services are facing at the moment. And there are a lot of questions in there. Some I know you can't answer, and hopefully I'll be able to answer some of those, getting access to RAT tests. So I guess more from a public health point of view, we asked Tony around what Tony's doing in Southern LHD within the LHDs to cope without having access to rapid antigen tests or to be able to get a PCR test for some people. So it would be great to hear from you about what services could be doing in the interim in a space of lack of access to testing.
Yeah, so the first thing is that if you've got a person who's symptomatic and you don't have a RAT test, a PCR test is a very, very, very good idea. Similarly, if you have close contacts who are having those tests done and you don't have access to RAT at this time, again, the turnaround times are improving. The testing can be done of those close contacts if RAT is not available. And that's certainly true in many of our regional areas where RAT may not be available at the moment, but they may have a good relationship with the local lab. So please, or the local pathology service. So please don't stop testing, but if there's no RAT available and you have a strong suspicion that someone has COVID, then please do get a PCR. It's been really, that's the first thing. I understand that there's work going on to try and make sure that RATs are getting distributed to vulnerable populations such as yours. But I think you possibly may have seen, because everyone was out trying to make sure we had enough photos of it showing that we just got 1.2 million rats. And now, as you can imagine, it's a bit of a, it's a nice way of putting it. I don't have a nice way of putting it. Everyone's trying to get their hands on the same thing. Yep. So basically, we understand that your services do cater to very vulnerable people. And I think that comes back to, are you a high risk setting? Mm-hmm. So a high risk setting is a setting where you have a whole group of people who, if they all get COVID at the same time, are going to have a very bad, or potentially have a very bad outcome from it. So from that point of view, if you are running a residential setting where you have a whole group of people who may already have pre-existing or other comorbidities along with other things that's going on in their lives, how disruptive will having COVID get into that setting being? So for most residential settings, I would suggest it would be incredibly disruptive and incredibly difficult to manage. And so doing what we can to try and keep it out of those settings as far as possible. So that's where, when you see any of that guidance that says avoid high risk settings, please do. If you do need to bring a staff member back who's had some higher level of exposure, they are able to come back under an exemption as healthcare workers. But then there is the risk that if they're not meticulous with their PPE use, that they can actually infect other workers and your people that you're providing care to. So I think it really is about that balancing of risk. And I've had some fraught conversations over recent days with many people where what's the risk if this person is not able to come to work versus what is the risk if I allow this person to work. And it really does come down to managers knowing their staff well. We all know who our people are who are fantastic and are COVID paranoid. And we also know our people who we're constantly seeing their mask being worn as a chin diaper. So depending, you know, that's why that individual risk assessment, and I know it must feel really hard for services that we're asking them to make these decisions now, but that's really what it comes down to, is how badly does this person need to be here for the safety of the clients you're looking after? Are there alternatives to having that person back? And where there are no alternatives, what's the risk that that person brings with them? Have they been triply vaccinated? Will they wear their masks? Will they not hang out with clients when clients are, you know, smoking or chatting or whatever else with a mask off? Those sorts of things, which are really hard barriers to have in place, but really important to understand before you put someone back into a high risk setting.
So you've answered a lot of of other questions that were on there, so that was really useful. So there has been a lot of uncertainty around are resi services a high risk setting? Does that mean that staff members need to get a PCR rather than a RAT test? So
if you're at the moment, if you're in New South Wales and you have COVID symptoms or you've been exposed to somebody with COVID, a RAT test is enough. Where you don't have access to a RAT test and you have a person who's a hermit and you have no idea how on earth this person could possibly have been exposed to COVID, but they may have been, they're the PCR. That's the hard and fast one. So if you're really symptomatic and you've got a 20-year-old in your life, or you've got other people that you know who have COVID, a RAT test is enough. You don't have to go and get a confirmatory PCR. The people who should have PCRs are the people where you've got no other clue where it could have come from, or when you can't get a RAT test and you're in a group that needs to be tested. Does that make sense? Once we've got the RAT tests out there, we can go back to using the PCR for the highest risk. One of the things that for your clients who aren't in your care right now, the PCR is one of the, depending on the turnaround time, the PCR is one of the fastest ways to get people into those local health districts' COVID care programs, simply because there's a good link between PCR testing and those COVID care programs. There's probably an extra 24 hours added on if it's a Service New South Wales notification of a RAT test. So it's not that it won't happen, it just takes a bit longer. But then again, with the RAT test, you've got the result instantly, and so you can catch up on that 24 hours where it doesn't need to get processed through a lab. So swings and roundabouts.
Thanks, Susie.
Can I just ask a follow-up question, Janet? I'm just wondering, when there comes a time where we perhaps do have better access to RAT, would you be recommending, what sort of schedule should people be expecting their staff to be taking a RAT every time they come to work? Should we still be saying only if you're symptomatic? Is there any thoughts around that frequency? I mean, will we have an opportunity where we have enough that we could do that, or should we try to be a bit sparing when we do get access?
So I think we've got, there are all sorts of phrases I've learned in the past week or two. The first one is RAT replete versus RAT deplete. So if we're in a RAT replete environment where there are RAT tests going everywhere, then yes, testing your staff on a daily basis, given the high acuity clients you have, particularly given the high prevalence of COVID in most areas of New South Wales, is not a terrible idea. We're not doing that right across all of our healthcare facilities, but we are recommending it strongly in most aged care facilities, for example. Doing a test with a RAT less than twice a week, if you're trying to use it as a surveillance, is pretty much useless. Don't just do it once a week. It's not going to save. You're better off saving your rats and telling anyone who's had a moderate exposure or a high risk exposure, preferably your moderate risk exposures. You'd like to keep the high risk ones out for a week or so, but people who've had a moderate exposure, be better off saving those rats and testing those people rather than burning them all through on everybody. I think it's really important to understand that there is that difficulty at the moment where guidance is being shaped, and I'll be quite frank, some of it is union driven as to who is being tested and not tested. Some of it is capacity driven as to who has rats and who does not have rats. And some of it is funding driven in the who pays for the rats. So at the end of the day, keep doing what you've been doing since day one, which is to make sure staff have that responsibility that if they've had an exposure, to let you know. And if they've had that exposure, do that risk assessment to see whether do they come into work today with a rat, or do they not come into work for a week and work from home. You work out what that is for you. And I think that's the best advice we can give at the moment. Things are changing really fast. In a world where we didn't have to worry about the waste that goes with ratting everybody every day all the time, and it is a big amount of waste, then, you know, in a wonderful world, we might rat people all the time, but that's not the world that we live in. And it's probably not the world that we do want to live in for the next 12 to 24 months either. But right now, we've got this force of infection that we just seem to be, I think we're all in here like this at the moment, because we're starting to see a slowing in that force of infection and a slowing in some of those acuity indicators where people in the community who may not have got tested turning up in hospitals. We're seeing a slowing of the growth of people coming into hospitals. So when people say, but you can't tell how many people are being tested, actually how many people are presenting and going into hospital is a proxy measure for us as well. But you know, I can say for our friends in Byron, in the last 14 days of the PCRs, there was 1,930 done and there were 1,900 positive. So that means we probably aren't quite doing enough testing. Most of our LHDs at the moment are somewhere, the lowest are out in Western, where it's about 15% positivity, and around Southwest Sydney and Western Sydney, it's about a 50% positivity of PCR at the moment. So there's still quite a few people out there who are ready to bring COVID to your buildings.
And just on that, Jan, Leonie, who is from the North Coast, from the Northern New South Wales region, has asked, how do you get a cluster of people with symptoms to a PCR test centre safely? Would the PHU unit assist in that? She mentions that their PCR took 6 days.
Yeah, so I think one of the things that we could do is start thinking about training people how to take the swabs. Once we've all got used to doing the rats on ourselves, it actually is not that hard to swab other people apart from the tears that come from their eyes. And then it's much easier to transport 6 swabs than it is to transport 6 people. And I know in Western New South Wales, one of the models in aged care was that the aged care provider was taught how to swab people. And that way, instead of trying to get a pathology collector who are very scarce on the ground to there, all we needed was a taxi to take the swabs to the lab to get processed. So I think it's worth reaching out to your LHD who you partner with to talk about what can we do to prevent having to either get your people out here testing, and it may not happen quickly at the moment, or how can we get the swabs off to a lab to be done.
Right. Thanks, Jan. And yes, so NADA will be working with the ministry around rats, and we also spoke about needing a procedure for services, both residential and non-residential services in NGOs, to provide some guidance to you all. We might move on from rats, I'm sure, Jan.
I didn't get to use the last one was one I picked up from Sydney Morning Herald, which is rat get, when you use a whole lot of rat tests and you find no one positive.
So one, I might go back to isolating into the workforce, because the workforce is a big issue in terms of making sure we have a workforce to be able to continue to deliver services. So a person said, if residential services are in fact a high risk setting, what is the isolation period for a positive staff member? Is it still 7 days? Is it longer in high risk settings?
So basically, the guidance is it's 7 days for a positive person. They should be completely asymptomatic for at least 24 hours, apart from perhaps a post-viral cough. But if the person's got a post-viral cough, they should check in with a health practitioner, whether it's a New South Wales health clinician or whether it's their GP, just to make sure that they haven't got anything else going on, because some people's post-viral cough is actually their post-nasal drip that they're still coughing up. Sorry, that's gross. Really sorry. I hope no one's eating lunch at the moment. But basically, make sure that the cough really is a post-viral cough before you let somebody who's coughing their guts up into your centre. But that's the most common persistent symptom. They should have had a resolution of, nose running, headaches, feeling tired. They might still feel like they've been knocked around, just like someone who's run a marathon might feel knocked around for a couple of days. But they shouldn't. I mean, I think we've all had a viral illness where that we've known when we're on the mend and we know where we've cleared it. It's not just coming back to work when you're on the mend, it's coming back when you're actually starting to feel like a human again.
Okay, thanks. So I do have another question, sorry to go back to testing again. What are the guidelines around taking throat swabs only where nasal swabs are being refused by a client? Is it confirmed that throat swabs more likely to be positive with Omicron?
I will happily take either. Honestly, both is great. Either is acceptable. If you can get a swab out of somebody's throat or out of their nose, if and it doesn't have to be a brain biopsy, it just has to be uncomfortable. It's past the turbinates, which I'm sure somebody can Google a picture of if they want to. But it's definitely not brain biopsy material. And so people who can't tolerate nose swabs, take a throat swab. People who can't tolerate throat swabs, take a nose swab. Both is great, but whatever we can get is what we take, honestly. And some collection centres only do X, and some collection centres only do Y, and some centres do one nostril and not two. But at the end of the day, if you have enough virus to be turning a PCR positive, I'll get it from either your nose or your throat.
That's great. Thank you so much for that. So there was a question that came through around deep cleans. Have things moved on from last year? When should residential services be doing a deep clean?
So basically, you should have an enhanced cleaning schedule. That enhanced cleaning schedule is meant to take care of if you've got someone with COVID on board. We got really excited about deep cleaning for a while there. We're not really now. So if you're doing your cleaning appropriately, as in accordance with the safe work guidance that's out there telling you how to keep your places clean, you're good. Don't go and spend $40,000 on specialist cleaning. No, right. I think you've all got better things to spend $40,000 on.
Absolutely. Well, at the moment that's rats, but let's hope that the New South Wales Ministry will be providing those free to non-government services and to clients of our services as well, is what we're really hoping for. We did have a question, and you may not be able to answer this, Jen, around whether the public health order is going to be extended to include the booster. Are you aware whether the public health order is going to be changed for healthcare workers to include the booster shot? So
I know there's been an announcement saying that healthcare workers, but I don't know that that's actually translated into a public health order. So look, I know a lot of people have been ambivalent about getting the booster. I am at the moment, one of my joyous things is I'm actually the arbiter of death when it comes to COVID. So people who pass on, I get sent every single death and have to review the record that's been provided to see, did COVID cause the death or was it incidental? And what we're seeing now is even some people who are particularly vulnerable, who are twice vaccinated, who haven't been boosted, are coming through in our numbers, both in ICU and in people passing. So my strong message is, please, wherever you can, just encourage people to get that booster, because whilst, yes, we might see people who pass or get really seriously ill with it, we're far less likely to. So please, especially amongst your staff, get them to protect themselves. They're doing an amazing job with people who, just like the rest of us, can be unpredictable at times. And I think it's really important that they get that full protection. They understand that there is still a risk out there. It's not gone away. Omicron is not necessarily mild. I think that's the other thing. I know people who've had 2 doses and were due to get their booster just, of course, when COVID came to visit. And they were really unwell at home, not, needing hospital unwell, but really unpleasantly unwell for 5 days at home, properly unwell, and couldn't work from home, couldn't do anything. So it's worth avoiding that, if you ask me, because I'm a bit of a wuss. I won't tell you that the words dying swan have been mentioned in my presence when I've had a viral illness.
Thanks for that, Jen. So we have had some questions, and I'm not sure whether they're obsolete now, which is around the 4 hours close contact. What constitutes 4 hours of close contact, particularly when you're talking about when you're working in a residential setting?
So basically, here's the problem. You have people who, under the public health order, must isolate under the public health order. And at that moment, the people under the public health order are the people who are household contacts or who've had household-like exposure. So that's the unfettered hanging out in your living room, either with your friends for a long period of time, a good evening of whatever people do in the evenings, or, hanging out together for an extended period of time in an informal setting. In the workplace, we've got the healthcare workers matrix where you can have a look to see who has had a high risk exposure. And that will often be where somebody else hasn't worn a mask, or where the worker hasn't worn a mask, and there's been an extended face-to-face conversation in an indoor environment, or where there's been just extensive interaction over a significant period of time. In those situations, we call those a high-risk exposure, and where possible, we are excluding those people from our workplace for 7 days. If we can't exclude them from the workplace, because without that person, everything dies. And please, business continuity, everyone, this is not going anywhere, and this will be how it is. It's really important to have that rat to come back to work. So keep them out. And get that rat back to work program going, rather than bringing them back saying, well, I don't have to leave you out. There's a public, you're not under the public health order. It does become problematic if somebody desperately does not want to come to work after a high risk exposure. And that's something else you may need to work, because we have to keep our workplaces safe. So if we do bring people back after a high risk exposure, we do really have to police, shared tea rooms. We really do have to become the police of masks. We really do have to be so careful about making sure people are doing the right thing around our vulnerable clients, and just looking after each other. So, I know I'm in the ivory tower of the ministry. We have had an incursion about once per week in my, larger team of 80 to 100 people. The way how they keep us going is the high risk exposures tend to get sent home, but we're lucky enough that we can work from home. And those who can't work, those who have a moderate risk exposure are managed with sorry, phone went. Are managed with daily rat to make sure we don't bring it in with us.
Thanks, Jan. And Susie has just posted the healthcare worker exposure matrix that Jan referred to. It is for public health workers, but I think NGOs can absolutely.
It's for everyone to use. It's not just for public health workers. It's our recommendation for how, if you're a private hospital, a private group, whoever, that's our recommendation about how to risk assess in this situation.
Brilliant. Thank you so much. So an issue that's come up is relating to people's paid leave. And because of how people are being notified or not being notified now by New South Wales Health, and some potential issues of being able to get access to some of the payments, the Australian Government pandemic leave payment, if they don't have sick leave. Is there any movement by government to provide some type of written confirmation that will support getting access to that disaster payment?
We are trying really hard to work with the Commonwealth particularly about this, and it is really hard. I've got nothing else. But the other thing you can do is you can try and help. If it's been an exposure in the workplace, you could always give your worker a letter saying this person was exposed to X, who, to a worker who had COVID-19 on blah, blah, blah. They've been excluded from the workplace after a high-risk exposure. Please consider them having a pandemic payment. I don't know if that will work, but
look, we'll do anything we can.
I'm very sorry.
But great to know that you're working with the Commonwealth to try and get a workaround.
We're doing our best, and if do go and knock on your local federal members' door and ask them about it too.
Great. So I did. Okay. Another question has come through. Our service is seeing clients in the community or on-site consultations. Many of the clients are vulnerable, vaccinated and unvaccinated. I would consider this a high-risk setting to some degree, even though not residential. We are encountering clients and staff testing positive. We have all the PPE, infection control procedures. Maybe too late in this meeting, but is there any further guidance for outreach services?
We do have guidance published for outreach services more generally about things to do to try and keep yourself and your workers safe. It's possibly buried with aged and disability care on the New South Wales Health website, but I think it is those basic things of calling ahead to find if anyone in the household that you may be visiting has COVID. Trying to make sure that if you do find someone who's symptomatic with COVID, encouraging them to get testing. It's really hard at the moment. Most of the local health districts have closed their special health accommodation simply because everyone wanted to go on holidays again, and the hoteliers thought that it was a more desirable clientele. But we are also trying to work with DCJ because we do know that it's become a real problem for some of our clients who don't have homes. Who, when they test positive and they're couch surfing, suddenly the couch is not there anymore. So it's a real issue and it's a live issue. So please be aware that we are trying to work that one through, but any advocacy that you want to make with Department of Communities and Justice on behalf of your clients, we would love you to help us.
Thanks, Dan. And just one last question, and it was mentioned by one of the services before. Should residential services be monitoring oxygen saturation for positive clients?
Look, I think the answer with that is if you've got a clinical protocol available that tells you what you will do, depending on what the oxygen saturation is, sure, go for it. But don't do it if you don't know what to do with the numbers. Otherwise assess them as you would normally assess a person. And if you need to call for help, call for help. So please make sure that if you do start moving into that space where you're providing clinical care for COVID, for a group of people, please make sure that you've got the appropriate clinical protocols and oversight around to do that. You might want to talk to your LHD about what your service is able to provide clinically, and then when you need the LHD. The other thing is a lot of your clients, if they do get COVID, they will be eligible for treatment. Early treatment with sotrovimab, and there are new antivirals coming. So it's really important that you keep that link with your LHD's COVID care in the community going, so that if you do find that you've got an unvaccinated client with COVID, with significant comorbidities, that they get that treatment with sotrovimab, because otherwise they're at higher risk of winding up in hospital. So please do keep that pathway going, and it may be about talking to that COVID care team to see if you can share protocols with them, and they'll tell you, this is the point where I need you to call us to give us, these are the things to help.
Great. Thank you so much, Dan. Look, I'm mindful that there's only 1 minute left to go. Any take-home messages for the drug and alcohol NGO sector?
Just to thank you very, very, very much. I know none of you have had a break with this, and you probably you got hit hard with Delta. Omicron is probably playing havoc with you all at the moment. And again, we are freeing up some of our public health unit capacity to do more work in the vulnerable settings. So a lot of the things that people have taken for granted, the interview from public health, the phone call from New South Wales Health that followed a positive test, they're all gone now. So as an advocate for your clients, to try and get them into appropriate care pathways is so really important at the moment. simply because we just, if they don't, because it's become an opt-in system, there are so many people who are at risk of not opting in and missing out on what could be life-saving care. So please be that advocate for your clients and try and help make sure that you've got that good pathway in to getting some additional care for your clients who are eligible. Thanks.
That's great advice. Thank you so much, Dan. We really appreciate your time. And Tony, also, thank you so much. Tony, there is another question which you aren't going to be able to answer, but I'd love for you to take it back to the ministry, which is, are we able to get increased funding for staff wages? We really need it at the moment to be competitive in a small pool of professionals. And I think that would come across all NADA members on that call. That would be super helpful right now.
I'll take that question back, Rob.
Thank you. It's appreciated. And look, to everyone, NADA will continue to advocate. Tony's been a great advocate for us as well on the AOD COP and on the Clinical Council, and we will continue to advocate. We'll copy the questions. If we didn't get anything, we'll come back to you, and please feel free to email or talk to any of us to make sure we can meet your needs. Thank you and be safe.
Thank you so much, everyone. See you later.
Bye-bye.